Second group is cardioselective or beta 1 specific or selective blocking agents. Metoprolol with the trade name of low pressure, atenolol, tenormin, and many other trade names, Zephnol and others. Acebutolol, Sectrol, Betoxolol, Carlon or Betoptic, Bisoprolol, Z-beta, Caliprolol, Esmolol with the trade name of Previbloc. Then alpha and beta blocking agents, mainly the labetalol with the trade name of Tendate, but also carvedilol. Carvedilol is also having some alpha and beta blocking activity. So the good student, they should remember also, other than labetalol, carvedilol. These are the two alpha and beta blocking agents. Then classification according to partial agonistic property or activity are drugs with intrinsic sympathomimetic activity or action. Alpranolol, oxpranolol, prectolol, pindolol, and acebutolol. Second group are the drugs without intrinsic sympathomimetic activity. Drug like propranolol, penbutalol, atenolol, metoprolol, sotalol, timolol, nadolol, and labetalol. Then classification according to membrane stabilizing property are local anesthetic like activity. They are also having quinidine like activity. So these are the drugs which have membrane stabilizing effect or property: propranolol, oxpranolol, alpranolol, acebutolol, and labetalol. Then the drugs which are not having membrane stabilizing effect or quinidine like effect or local anesthetic effect. The examples are prectolol, atenolol, metoprolol, pindolol, sotalol, timolol, and nadolol. The important properties of these important beta receptor blocking drugs, we can see that because propranolol is a prototype drug, we'll discuss propranolol. We can see that according to selectivity, as we have already discussed the classification, we can see that acebutolol, atenolol, betoxolol, bisoprolol, all they are cardioselective because they block selectively beta 1. Likewise, caliprolol, esmolol, and metoprolol, they are blocking the beta 1 receptors, so they are cardioselective. That means they don't block the beta 2 receptors, which are mainly in the bronchial tree or bronchial smooth muscles, while these which are not having, which are non-selective, they block both beta 1 and beta 2, so they don't have selectivity for only beta 1, so they are declared as none. That means the selectivity, they block both beta 1 and beta 2. As far as partial agonistic activity is concerned, acebutolol has partial agonistic activity, likewise cartriolol and caliprolol and labetalol and penbutalol and pindolol, while all others, they don't have partial agonistic activity or intrinsic sympathomimetic activity. Then local anesthetic action, are membrane stabilizing effect, or quinine-like effects. Acebutolol has, butoxolol has light local anesthetic activity or membrane stabilizing activity, while labetalol and metoprolol and then pindolol and propranolol, they have local anesthetic or membrane stabilizing effect or quinine-like effect, which we have already discussed, classified according to these. Then as far as the lipid solubility is concerned, because if those beta blockers which are highly lipid soluble or have moderate activity, they can cross blood-brain barrier, so they will be having more effects on the CNS. So one has to be particular about this lipid solubility. That drug like the penbutolol, you see penbutolol and propranolol, they are highly lipid soluble. That means they can cross blood-brain barriers. So the CNS related effects, they are more marked with these drugs. Are like labetalol and metoprolol, they have moderate lipid solubility, while all others, they are mainly water soluble. That means they don't cross blood-brain barrier, so they have less CNS related side effects. But these propranolol and penbutolol, they have high lipid solubility, so their concentration, the CNS will be very high, and they will have CNS related effects, like they are going to disturb they can produce depression, they can produce fatigue, they can produce disturbance in sleep, fatigue and lethargy. Then elimination half-life depends upon metabolism as well as the renal functions. So drugs which are easily excreted in the urine, if the renal function they are disturbed, we have to be particular about, because their elimination half-life will be prolonged. Like nadolol, if you see nadolol, the elimination half-life is up to 24 hours, and if the renal function they are a bit disturbed, that is going to prolong further. So likewise butoxolol and those which are having elimination half-life, we have to be more particular about their renal functions, and those which are metabolized like propranolol and metoprolol, which are extensively metabolized in the liver. So there we have to be particular about the status of those patients. Either they are extensively metabolizer or poor metabolizer, because that is going to affect the plasma concentration, because that is going to be the extensive metabolizer, they will metabolize these drugs at a faster rate, while poor metabolizer, they will be metabolizing the drug at a slow rate. Bioavailability, if you see on the last approximate bioavailability, we can see that more than this penbutolol, the bioavailability is more than 90%, pindolol 90%, likewise with cartirol and this butoxolol 90%. So these drugs which are having bioavailability is very high, so we can achieve the plasma level easily, and we have to be particular about those drugs which are metabolized extensively like propranolol and pindolol and metoprolol and atenolol, which are extensively metabolized in the liver, because those drugs which are going to induce these enzymes system of the liver, they are going to increase by enzyme induction, they are going to increase the metabolism of these drugs, while those which are enzyme inhibitor like cimetidine and antifungal drugs, so they are going to decrease the metabolism of these drugs. So if we have to administer, say for example, the patient is taking cimetidine, which is going to inhibit the metabolism of these extensively metabolized drugs, so the metabolism of the drug will decrease. So this is very important in drug interaction at the pharmacokinetic level or metabolizing level. So we have to be particular that this important drug interaction should be acknowledged, otherwise there will be either the toxicity or there will be failure of the treatment, because the metabolizing enzyme they have been induced by these drugs, so they are going to increase the metabolism of the drugs and the patient will have the failure of the treatment. As far as the clinical uses of the beta blockers is concerned, we are using beta blockers. You can see a long list of the therapeutic indications where we can use beta blocker. As I told you in the earlier, is to start with that these are very commonly used drugs. For example, hypertension, because beta blockers they are going to decrease the cardiac output. Main effect during hypertension, the role of beta blocker is mainly by the action on by blocking the beta 1 receptors in the heart. These are going to produce negative inotropic and negative chronotropic effect. That means they are going to decrease the force of contraction as well as decrease the heart rate. So by this action mainly on the heart, beta blocker they are going to decrease the blood pressure in mild to moderate hypertension. They are very useful, especially when the sympathetic tone is high. But as we know, beta blocker they are the vasoconstrictor, because when we block the beta receptors, what is going to happen, the alpha receptor they are free. So now the norepinephrine which is released will act on alpha receptor. So if we are called, or if you ask the question, beta blocker are they the vasodilator, the answer is they are the vasoconstrictor. So we have to, but by their action on the heart, and secondly by inhibiting through their action on the beta 1 receptors in the kidney, they are going to decrease the release of renin, and this renin is going to stop. A decrease in renin is going to decrease the conversion of angiotensin to angiotensin 1 and angiotensin 2, which is a very strong vasoconstrictor. And also this renin angiotensin system is going to also cause salt and water retention. So all these changes that is going to operate, and on prolonged use of beta blockers the peripheral vascular resistance will decrease. Although as I told you earlier that the beta blockers they are the vasoconstrictors, but when we use chronically for prolonged period through other actions other than the blood vessels, through its action on mainly on the kidney, release of renin, by decreasing the release of renin, and then angiotensin 2, and also on salt and water release of aldosterone. So all these effects they are going to cause vasodilatation or decrease in peripheral vascular resistance. So this is going to, so in hypertension the role mainly by the action on heart, beta 1, negative inotropic as well as negative chronotropic, that means the heart rate is decreased and force of contraction and cardiac output will decrease. And secondly by its action on the kidney through decrease in release in renin, the beta blocker they are going to decrease peripheral vascular resistance, as well as they are going to decrease the sympathetic tone from the CNS. So those which are highly lipid soluble, they are going to also affect the sympathetic tone from the vasomotor center. So all these changes, they are going to be beneficial in the treatment of hypertension, mild to moderate hypertension. But there is a retention of salt and water, so that can be overcome by use of diuretics along with beta blockers. But one should be very careful that when the patient is on beta blockers, he should not be given calcium channel blockers, especially verapamil and diltiazem. Otherwise, this is going to augment its heart blocking or block at the AV node, so it can lead to complete heart block. So it's a serious pharmacological or pharmacodynamic interaction that the beta blocker should not be combined with calcium channel blockers, verapamil and diltiazem. So this is how we can, and also this effect on the CNS, that means it's going to produce drowsiness, which is also beneficial for the anxious patients. Then the second use, ischemic heart disease. The role of beta blockers, how they are going to be beneficial and how they are going to be useful in case of ischemic heart disease. So beta blocker, they are very useful when we are dealing with a case of stable angina or classical angina or angina on exertion, because the beta blocker, they are going to decrease the heart rate, they are going to decrease the force of contraction of the myocardium, and they are going to decrease the requirement of the myocardium or oxygen requirement of the myocardium. So all these changes, they are beneficial. They are going to decrease the oxygen demand of the myocardium. So they are useful in stable angina or classical angina or angina on exertion. During exercise, they are going to decrease the frequency as well as the severity of the pain in ischemic heart disease. But they are contraindicated in case of Prince metal or vasospastic angina. So this is a precautionary measure that when you are prescribing, the beta blocker should not be prescribed in a vasospastic angina or Prince metal angina. Then as far as the cardiac arrhythmias are concerned, the beta blockers, they are useful in supraventricular tachycardias or arrhythmias, but they can be used in ventricular arrhythmias, especially those which are induced by atherosclerosis or angina. So ventricular arrhythmias, if they are by ischemia of the myocardium, so they can be also managed by beta blockers. Otherwise, supraventricular tachycardias or arrhythmias, they can be managed by beta blockers, because they are going to suppress the activity of SA node and AV node, and they are going to delay the conduction, and they are going to be useful in supraventricular tachycardia or arrhythmias. Then in the case of heart failure, the beta blockers, they should be used only in chronic heart failure, not in acute heart failure. So chronic congestive failure or stable heart failure, because these beta blockers, especially these three, when you are asked, you have to name the beta blockers, you should remember the three names: metoprolol, bisoprolol and carvedilol. These are the mainly and the only beta blockers which are used for the treatment of chronic heart failure, because they are going to decrease the possibility of sudden death as a result of arrhythmias, as a result of heart failure. So they can be used safely with low dosage and slowly and gradually increasing the dose. So metoprolol, bisoprolol and carvedilol, these three names should be remembered when you utter the indication of beta blocker in chronic heart failure, not in acute heart failure, because in acute heart failure they are beta blocker, they are going to even maybe very dangerous. Then in case of obstructive cardiomyopathy, beta blocker they are useful because they decrease the heart rate. So in obstructive cardiomyopathy they are going to increase the cardiac output, they are going to increase the perfusion of the myocardium, so they can be used. Likewise in Fallot's tetralogy, beta blocker they are useful to decrease the symptoms of Fallot's tetralogy. Fallot's tetralogy is a congenital anomaly in the heart, where there is a missing of the interventricular septum, there is a coarctation of aorta, and this is going to be beneficial in Fallot's tetralogy, and that means these the symptoms of Fallot's tetralogy, cyanosis and orthopnea, dyspnea, that is going to improve by slowing the heart. Then in case of dissecting aneurysm of aorta, because it is an acute emergency and if we delay, that can lead to fatal outcome. So but to inhibit the dissection as a result of aneurysm of aorta, so we can give beta blockers which are going to decrease the further dissection of the aneurysm of aorta. So till we put the patient on for operation, we can use beta blockers to retard this process of dissection of aneurysm of aorta. Then in the treatment of hyperthyroidism, although the disease is of the thyroid gland, there is excessive release of the T3 and T4, but symptoms are like tachycardia, palpitation, perspiration, and all they are anxiety. They are like there is excessive release of the corticosteroids, the release of norepinephrine. So by blocking the beta receptors, the most of the sign and symptom of hyperthyroidism can be controlled. So beta blocker they are useful when we are treating hyperthyroidism or thyrotoxicosis, mainly by blocking the beta receptors. Tachycardia, tremors, anxiety, perspiration can be controlled. Secondly, this beta blocker they also decrease the conversion of T4 to T3, so that is also beneficial in hyperthyroidism. But the answer is either the surgery or the medication, specific medication, which is going to decrease the release of T3 and T4. But to control the sign and symptoms of hyperthyroidism, we can use beta blockers. Then the treatment of pheochromocytoma, which is a tumor of the adrenal medulla, there is excessive release of epinephrine and norepinephrine from the adrenal medulla. But when we are, as we discussed with alpha blockers, when we are treating a pheochromocytoma, the beta blockers they are contraindicated, because what's going to happen that if you start, say for example, you make the diagnosis of hypertension, but you don't know that this is a case of pheochromocytoma. If you start beta blockers, these beta blockers they are going to block the beta receptors, but the alpha receptor they will be free, and epinephrine, which is released from the pheochromocytoma or adrenal medulla, that is going to act on alpha receptors, and alpha receptor they are vasoconstrictor. So what will happen? The use of beta blocker, instead of correcting or lowering blood pressure, the patient will come with the complaint that doctor, since you have started the medicine, my headache has increased and my blood pressure has increased. So whenever beta blocker they are started, especially in young people, and there is a hypertension is not controlled, you should think that this may be a case of pheochromocytoma. So you start first the alpha blockers and then beta blockers, or you start with those drugs which are blocking both alpha and beta, like labetalol or carvedilol. So, but beta blocker should not be used in the treatment of pheochromocytoma to start with. They should be followed. First you start alpha blockers and then you give beta blockers. Then in the treatment of glaucoma is increased intraocular tension. So beta blocker they are going to decrease the synthesis of aqueous humor. So they are useful in the treatment of glaucoma, which is the most common cause of blindness all over the world. So the beta blocker they should be used to control intraocular tension. But those which are having local anesthetic effects, those beta blockers, they should not be applied in the eye, because they are going to produce local anesthesia of the cornea, which can lead to corneal ulceration, because the patient will not be having pain and protective reflexes they are blocked. So those beta blockers which have got local anesthetic activity, they should not be given locally in the eye, otherwise it can lead to corneal ulceration. Then in the treatment of migraine headache, which is a vascular disease, and there is mostly unilateral headache which is in attacks, and there are some precipitating causes, maybe during menses, or any anxiety or tension, or any food can precipitate the cause. But the beta blocker they are useful for prevention of the migraine attacks. If the frequency of the migraine attacks is very high, say for example twice a week or more than that, if the patient is getting migraine, you can start beta blocker. They are very useful in prevention of migraine. Then in the treatment of anxiety or stage fright, those people are performance anxiety, drama performers or stage or actors, or even the players or the students, or even some people who cannot face the exam. The beta blocker, propranolol, simple, one tablet of 10 milligram may be a wonderful thing. The patient won't have anxiety or fright, stage fright, or he will appear for the examination. So you can use beta blockers for the treatment of anxiety or these difficulties in performing these things. As far as the cirrhosis, which is a liver problem, there is fibrosis of the liver. So and there is a esophageal varices, there is chances of bleeding, but these beta blockers they can decrease the chances of bleeding when the patient they are recurrently they are and frequently they are bleeding from the esophageal varices. You can give beta blockers that is going to decrease the possibility and chances of bleeding from the esophageal varices. So, but the answer is either you inject in those varices, or you go for other treatment of the liver cirrhosis, that means the liver transplant. Then in the treatment of tremors, this essential tremors. They can be controlled by use of beta blockers. Some people have fine tremors. It's difficult for them to, when they are writing or they are performing, they have tremors. So to control those tremors, we can use beta blockers. Then in alcohol withdrawal, when the patient was alcoholic and when he will withdraw, he will have anxiety, he will have tremors, he will have other tachycardia. So to control all these symptoms of alcohol withdrawal, we can safely use beta blockers for this indication, and the patient symptoms of alcohol withdrawal will be controlled. Then as far as the toxicity of beta blockers are concerned, it is mainly the toxicity is mainly our adverse effects of beta blockers. They are mainly the extension of the pharmacological effects. For example, when the beta blockers they are used in the case of asthma or COPD or chronic obstructive pulmonary disease, this is very dangerous because they are going to block, especially the non-selective beta blockers, they are going to block the beta 2 receptors. So the patient will have acute attack of bronchial asthma. So one has to be very careful when there is a history of bronchospasm not to use non-selective beta blockers. Yes, cardioselective beta blockers, they can be used, but one should be careful because the selectivity it's not highly selective. One in high dosage they can block the beta 2 receptors, so the patient can have bronchospasm. If you are using for hypertension or for the ischemic heart disease, one should be very careful, or the arrhythmia, that he should not have this problem of bronchial spasm. Otherwise, the patient will be will increase the agony and will increase the problem of the patient. Then as far as the second important side effect of beta blockers is concerned, that is the bradycardia, because beta blockers this is a normal effect of the beta blockers by blocking beta 1 receptors, but it is going to, all these beta blockers, they are going to cause maybe second degree heart block or third degree heart block or complete heart block. So one has to be careful, or if there is a problem of bradycardia but you have to use beta blockers, you can choose those beta blockers which have got intrinsic sympathomimetic activity, so that is not going to decrease the heart rate to that extent which may be problematic. And then you can also have problem when the patient is diabetic, because especially insulin dependent diabetics, because hypoglycemia, to combat the hypoglycemia which is insulin induced, so one has to be very careful when you are using beta blockers, because this hypoglycemia as a result of excessive dose of insulin, because there has to be to combat this hypoglycemia, one has to secrete glucagon. So but the beta blocker, they are going to decrease the release of the glucagon, and the hypoglycemia will be prolonged. So one has to be very careful. Secondly, when you are using insulin, hypoglycemia, which may be a part of the treatment, because that's the most common side effect of insulin, so that hypoglycemia is presented with tachycardia, tremors, perspiration and anxiety. So all these symptoms of hypoglycemia will be masked. So the patient will be in hypoglycemia, but the symptom will be masked, and the patient won't have problem. So one should be very careful when the patient is insulin dependent diabetics, that means type 1 diabetes. So otherwise the patient will have prolonged hypoglycemia. Secondly, the most of the sign and symptom of hypoglycemia will be masked, and the patient will have because the hypoglycemia is more dangerous, and shortly the patient can have very severe complication. Then other side effect is of use of beta blocker is because it is going to produce metabolic defect. There is increased concentration of VLDL, or very low density lipoprotein, and there is a decrease in HDLC, or high density lipoproteins. So both these changes, they are going to increase the process of atherosclerosis. So when you have to use beta blockers for a long period, you should ask for lipid profile after 6 months or 1 year, so that the process of atherosclerosis should not be enhanced. Then also the beta blockers, when they are used, sometimes they can produce sexual disturbance, because although the ejaculation is controlled by alpha receptors, but the beta blockers, when they are used, that decreases the sexual activity. So the people will have the problem when you start beta blockers. They will have the complaint that, doctor, since we have used this your drug, that has taken our sexual life and decrease our sexual desire, so one should consider you have to change the drug. So these are few important side effects. And drug interaction, as I told you, mainly from pharmacokinetic, that means those which are being metabolized by liver. So liver function should be kept in mind. And secondly, those drugs which are enzyme inducer or enzyme inhibitors, when they are also given along with beta blockers, which are metabolized by the liver, the metabolism will be affected by those enzyme inducer or inhibitors. Are those drugs which are excreted unchanged through the kidney, then the kidney function should be kept in mind. And then pharmacodynamic important in drug interaction is when you combine beta blockers with calcium channel blockers, especially verapamil and diltiazem, because that can augment the bradycardia or complete heart block. So one has to be very, very careful. And